I think our raise of hands just proved it, that over 80% of shoulder arthroplasty surgeons do less than 10 shoulders a year, and at least 25 shoulders per year is required to maintain that similar skill. So that's the reason why we require a good pre-op planning. And in this, X-ray historically was the pre-operative test which we used to do, followed by now the 3D CT, which we all do for essentially all cases, but still some cases, complex cases are misinterpreted in this. Now we have a gold standard which is required for almost all cases, and this is the investigation which is required for all our software planning. So why do we have to plan? First to find the bone deformity and to definitely correct it, so that our final reverse shoulder implant are having a good muscle balance to avoid any overstretching. So we have good investigations and randomized controlled trial where these matrices, which are required to say it is a wonderfully done a reverse shoulder, that is, and have a good functional outcome. One, first would be your more than 10 mm of a screw or a post should be there in the host bone, which is at least 50% more, 50% is base plate would be sitting, and more than 50% of the screws are with the native bone, and we have a good variability with the versions of at least 10 degrees of antegrade to 10 degrees of retrograde. And inclination, would we have to aim it at 0, but never superior. And lateralization, you would want lateral the component at least 2 mm lateral to the inferior glenoid rim. And lastly, we would have a good nice and low overhang of inferiorly of not more than 5 mm. To avoid scapular notching and therefore fracture. So why are these important? If it is well within the matrices, we can do a traditional RSA. If they require a bone block, we can use a metal augment or a bio RSA. If it is not, then we can plan on a hemi-reverse shoulder or a patient-specific implant or resection or fusion. So this is a good article I came across where it tells about 10 technical aspects of base plate fixation in a reverse shoulder without the glenoid bone loss. So the 10 aspects would be: one, this screw insertion angle, screw orientation, screw quantity, screw length, and your screw type. So screw insertion angle should either be parallel or divergent, should never be convergent. Screw orientation, it is inconclusive. You can orient the screen until unless you have a good purchase. Screw quantity, as an increase in the screw quantity, your chance of there will be less micro motions, in turn may lead to increased chance of acromial fracture. The screw length should be more than 30 mm, and the screw type at least minimum of 2 locking. And coming to base plate tilt, position, version, and rotation and design. So base plate tilt should always avoid superior tilt. Position should be always inferior, like I told. And it inconclusive about the version, rotation, and design. We can use any round, flat, or even a curved or oval. So of any company of inconclusive. Because starting with the X-rays, X-rays in a gracious view or a AP view, it is a static, tells about a static instability. It doesn't give much of information to, it's just a grading. And if at all your lateral edge of the acromion is in line with the lateral shaft, it suggests that there is a central erosions. This is the Hamada classifications. And the axillary, there's a so-called truth view, where this is actually helpful in knowing, one, if it's your head is decentralized. If it is anteriorly, that suggests that there is a superior, there is a subscap tear. And to know about the glenoid erosions and the glenoid bone stock. So there's a new measurement angle, that is an RSA angle. So this angle helps us how much angle or how much correction is required so that our screw or the post is parallel to the suprascapular fossa. But there is no clinical difference, and always the inclination, if it is superior inclination, there's a great chance of failure. So again, the Habermeyer classification tells us about the vertical glenoid erosions, and because we are talking about CT, this is of not much use. And coming to our now present gold standard, a CT scan, which is helpful in precision of glenoid bone loss and a glenoid version. It helps us in calculating the humeral alignment and even the joint space narrowing, and tells us more about the osteophytes. And if at all we are doing in fracture scenarios, it tells us to know about the pattern. And it is required for all software planning, and also tells us about the fatty infiltration. What not to speak about the CT when we're talking, we have to talk about Walsh criteria. This, nowadays there's a lot of modifications, D and E, but we'll be mostly focusing on A, B, C, where A, it tells us about the minor and the major central erosions. B talks us about the posterior joint space narrowing and any posterior bone loss. And the C, that is a biconcave, where the humerus is posteriorly subluxated and soft tissue, there will be lot of contractures. Again, the forward also tells us about the erosion pattern, where how much amount of correction needed to be orthogonal to the supraspinatus fossa, where the E is normal, E1 is superior, E2 is inferior, middle central erosions, and E3 is your inferior erosion. Why do we still tell this is not correct? That's because there's a study by 5 surgeons where 151 cases and independent views have suggested that after calculating the 2D and the 3D, 5 surgeons have changed around versions in 15% of the cases, inclination in 27% of the cases, and majority of surgeons have totally changed the design of the implant. Why? That's mostly contributed to the minor scapular rotations, and it is told that 15 degrees of scapular rotation can lead to up to 10 degrees of error in glenoid measurements. And this also fails to identify the point of great wear in the glenoid fossa, and absolute 5 degrees of errors are seen in on an average, and more than 20% have an error of up to 10%, 10 degrees. So 3D CT is the gold standard now for all softwares. This is required, where it helps in calculating a precise assessment of both glenoid and even humeral pattern, and even the scapular positioning. And it can be a shared decision along with the patients also regarding how much amount of erosions are there, and also present for the medical education. Just give me 2 minutes. So this is a good software planning of Arthrex VIP, where now they are coming up with even with the simulation and even the osteophyte calculation, where here you can actually, after the 3D calculation, you can see which implant options also you can use. As of now, they have a MGS, they have a universal also, but now in this you can use an MGS, where you can choose how much, what post or a screw can be done, and how much, if they currently don't have an augment, I believe, and lateralization also up to 0 to 2 and 4 also can be. And the central screws, if depending upon how much, 20, 25 or 30, but you should always try to avoid direction of the central screw posteriorly to avoid any scapular spine fractures. And here we can also, now moving on to the implant, where versions also can be selected, and inclination. Like we already told, versions, we have a great variability of 10 degrees of anteversion and 10 degrees of retroversion. Inclination, never superior. And glenosphere also, or larger the glenosphere, better is the movement and lesser the amount of notching. And this, the direction, at least minimum of 2 locking screws have to be there. And the direction of the screw doesn't matter unless you have a good purchase. And also the humeral also can be changed after this all have to be done after the osteophytes removal intra-op. And depending upon 135 or 155 also can be controlled, and the stem size also can be controlled in this. Thank you.